Good morning, good afternoon, or good evening, wherever you're joining us from. My name is Neil Johnson, and I'm delighted that you have decided to join us for the Global Heart Hub LinkedIn Live, where today we're focusing on ASCVD, the abbreviation for atherosclerotic cardiovascular disease, more specifically, in fact, high cholesterol. I'm hoping you know of us, the Global Heart Hub. We're an international umbrella alliance of heart patient organizations. And we're here today to talk specifically about ASCVD, and here's some of the reasons why. As many as 300 million people worldwide are affected by atherosclerotic cardiovascular disease. And for those of you who are not familiar what this is, in simple terms, it's the buildup of fatty deposits in the lining of the artery, which develop into a plaque, and as a consequence of that, of course, is that it causes a heart attack or a stroke. And ASCVD accounts for over 85% of all cardiovascular deaths that can lead to a heart attack and stroke. So it's a very serious public health issue. And I'm delighted today to be joined by a panel of experts. In fact, I can say a panel of friends, because in recent years we have shared the stage on a number of occasions, given that we're all on the same common mission of trying to tackle and reduce the burden of ASCVD. So I'm going to ask each of our panelists, and I'll call them as they appear on my screen, to just introduce themselves, their name, their title, and their organization. So perhaps, Sean, I can start with you.
Thanks, Neil. My name is Sean Goodman. I'm a cardiologist and the associate head in the Division of Cardiology at St. Michael's Hospital, affiliated with the University of Toronto. I'm also cross-appointed as an adjunct professor at the University of Alberta in Edmonton, another province, another city in another province in the big country of Canada, where I help to co-direct a research center that focuses on patients with atherosclerotic cardiovascular disease.
Thank you, and great to have you, Sean. And on your side of the world, but further south, Fernanda, all the way from Brazil. Good to have you.
Yeah, thank you, Neil, for inviting us for this event. It's an honor for Instituto Lado a Lado pela Vida, that means Side by Side for Life Institute, to be part of this important conversation. I work as public and international affairs at Lado a Lado, a Brazilian healthcare think tank founded by Marlene Oliveira, a social entrepreneur, in 2008. And our major areas of activities are cardiovascular disease, cancer, and men's health. And
great to have you with us. Thank you for making the time this afternoon. And now popping over to Europe, and I'm joined by Magdalena de Cord. Magdalena, will you introduce yourself?
Absolutely. Thank you once again for the invitation, Neil, and the Global Heart Hub. My name is Magdalena de Cord, and I'm Chief Executive of FH Europe, the European network of patient organizations advocating for people with inherited lipid conditions. Among them, what we're going to discuss today is familial hypercholesterolemia, in short, FH.
Super, thank you. And finally, but not at all least, and I'm going to have difficulty pronouncing your name, Professor Ur Grushel. Can you introduce yourself?
Thank you very much, Neil. It's a pleasure to be here. I'm a pediatric lipidologist and associate professor of pediatrics at University of Ljubljana, Slovenia. I'm taking care for hundreds of kids with elevated cholesterol and also other rare lipid disorders. And I lead the National Universal Screening Program for FH in Slovenia.
Fantastic, and great to have you here. So let's get straight into it, and maybe we go first to our medics. Start with you, Sean, if I can. Can you give us an overview of what cholesterol is, and what do we mean by unhealthy cholesterol or bad cholesterol?
Absolutely. So as you already started us off nicely in the introduction, Neil, cholesterol, the fats, the lipids are a soft, waxy substance that's made by our bodies. They're actually normally found in the blood and in every cell of the body. Cholesterol is a vital building block for cell membranes and hormones and certain vitamins. So without cholesterol, our bodies couldn't function. Now, cholesterol is transported in the blood in tiny protein jackets, what we call lipoproteins. And one of the many major lipoproteins circulating in the bloodstream is something called low density lipoprotein cholesterol, LDL-C, which is typically known as the unhealthy or bad cholesterol. Now, it's important to recognize that the vast majority of the cholesterol that's circulating in our blood is made by our livers. So approximately 20%, it varies from person to person, but approximately 20% of cholesterol that's in the blood comes from what we eat, mainly from saturated fats and trans fats and foods. But it's important to recognize that even if we eat properly, our livers may still make more cholesterol that circulates in our blood than our arteries would like. And so dietary cholesterol is important, but it doesn't affect blood cholesterol levels to the same extent in all individuals. And again, while our body needs cholesterol, cells can make their own cholesterol. They're not dependent upon circulating blood cholesterol levels, including LDL cholesterol, which is really kind of a junk protein that I think we've inherited as part of the evolutionary process that only appears to play, if anything, a harmful role.
So it's largely a naturally occurring substance, but of course there's a problem when we produce too much of it. What are the risks associated with high unhealthy cholesterol levels?
So the main risks with high LDL cholesterol levels is related to cholesterol entering the walls of our blood vessels. So there's an unhealthy cholesterol or bad cholesterol accumulation that, as you mentioned in the beginning, can ultimately form what we call atherosclerotic plaques in the walls of the artery. And this leads, of course, to something called atherosclerotic cardiovascular disease, ASCVD. It's interesting, the word atherosclerosis comes from the Greek words athero, which means pasta or gruel, and sclerosis, which means hardening. And that describes the fatty substance, the bad cholesterol, that forms a plaque inside of a hardened artery. So this fatty buildup in the walls of the arteries, unfortunately, in some cases, can lead to some sort of rupture, erosion, ulceration. Sometimes cholesterol crystals can penetrate that cap that overlies the atherosclerotic plaque sitting in the wall of the artery. And then once the contents of the plaque are exposed to our bloodstream, as our body tries to heal things up, it actually can ultimately, unfortunately, form a clot. Thrombosis is the medical term, that then can lead to an incomplete or sometimes a total blockage or occlusion of an artery, and then lead to catastrophic events like a heart attack in the heart muscle and strokes in the brain.
The numbers around ASCVD, Sean, are staggering, frighteningly so.
Yes.
Estimated 2 billion people are at risk globally, for example, of high cholesterol levels. From your point of view, can you talk to us more about the impact of ASCVD?
Absolutely. So you're right that we think that about 2 billion people on this planet are at risk, and there are probably approximately 300 million people currently living with atherosclerotic cardiovascular disease globally. So this fatty buildup of the unhealthy cholesterol in the walls of the arteries that leads to ASCVD includes the narrowings or the blockages that form in the walls, and that restricts blood flow. So that prevents the red blood cells that normally carry oxygen and nutrients from reaching our vital tissues like the heart muscle and the brain. And from a clinical perspective, how do we know that people have ASCVD? Well, cerebrovascular disease like transient ischemic attacks or strokes in the brain is one way that ASCVD can manifest, with narrowings and blockages in the arteries that lead up to the brain, for example. I'm a cardiologist, and so I focus typically on coronary artery disease. People can have chest discomfort, they can have breathing difficulties. If there's a prolonged blood flow blockage, permanent damage to the heart muscle, a heart attack can occur. And then finally, we shouldn't forget that peripheral to the heart, at least, and peripheral to the arteries leading up to the brain, we have many arteries throughout our body, and they can also develop atherosclerotic cardiovascular disease, narrowings or blockages. For example, restricting blood flow to the lower limbs, like the legs. And so people can be walking and get cramps in the back of their legs, not the ones that wake you up in the middle of the night, a muscle cramp, but discomfort in the back of the legs called claudication, that is a sign of atherosclerotic cardiovascular disease in the extremities. And so ASCVD, unsurprisingly, is far and away the leading cause of death around the world. About a third of deaths are caused by ASCVD. So that translates in absolute numbers to about 15 million deaths per year. And this is increasing over the past 15 years or so when we've looked at this, and unfortunately expected to rise even further. In fact, in the last minute or two when we've been discussing this, approximately 34 people with ASCVD have died from a heart attack or a stroke.
Yeah, we will touch later on the fact that for me, it's almost unbelievable that given the burden and scale of ASCVD, that there's to some extent almost a complacency or an acceptance about the level of damage that's been caused by this. Now, interestingly, it is the case, isn't it, that unfortunately, one of the things about the buildup of ASCVD is it's asymptomatic. We don't really know as such that we are developing this condition. Will you talk a little bit about that?
Yes, there are a number of risk factors that we can identify that can help people hopefully identify their risk and maybe get appropriate measurement of their cholesterol and potentially get treatment to try to prevent the consequences of ASCVD, in the so-called silent phase before it actually manifests, becomes apparent with something catastrophic like a heart attack or a stroke or a death. And so things that we can't sort of modify by lifestyle changes include a premature family history, an inherited condition. And I know Magda and Professor Grosho will talk about this a little bit more, but FH, familial hypercholesterolemia, is certainly something that's got genetic relation, and we can't change that, of course, but having an increased awareness of our family history for premature atherosclerotic cardiovascular disease in particular is something very important. The other things that are not typically modifiable, of course, is we continue to get older, and with older age comes a higher risk of developing ASCVD. Sex can determine the risk. We think that women are somewhat protected by hormones prior to menopause, but unfortunately they do catch up. This is an equal opportunity disease in both men and women, and so we have to pay attention to that. Now, while we can't change the genes that we've inherited, the good news is that up to 80% or more of premature cardiovascular events can be prevented, including by lowering unhealthy levels of cholesterol. And so things like smoking and stopping smoking or being exposed to secondhand smoke, high blood pressure, diabetes, our diet, there's psychosocial factors like stress. These are all things that with a healthcare professional, one should investigate, discuss, look at to try to catch it at the quote unquote silent phase before it becomes something catastrophic. And so I also want to, and my last point, emphasize that the unhealthy or bad cholesterol unfortunately isn't restricted to the story of LDL cholesterol. There are other what we call atherogenic lipoproteins that can lead to the cholesterol getting into the walls of the artery, can lead to atherosclerotic cardiovascular disease. One of them is called lipoprotein a, LPA. And there is a growing awareness that LPA is yet another inherited cholesterol condition that I know Magda can tell a little bit more about later on in the broadcast.
Yeah, and that's actually a great segue to Professor Groschel, because you mentioned the fact about genetics, for example. And I think one of the problems in common parlance is that very often people put down high cholesterol to lifestyle, but that's not the case, Professor Groschel.
Yes, exactly. So, in this relatively vast group of people with elevated cholesterol, there is, we could say, one particular group which doesn't have equal opportunity. So, their opportunity is actually quite, I would say, diminished because it's unrecognized in its genetics, and they are having extremely elevated cholesterol levels from birth on. So I'm referring here to the familial, which means inherited hypercholesterolemia. So what is, we will also call it FH. So what's this condition? Those of us who deal with rare diseases, we are usually used to incidences or frequencies of diseases less than 1 in 2,000. But all of a sudden, here is a genetic disorder with frequency much higher, about 1 in 300, which is, I would say, kind of unheard of in among these inherited genetic conditions. So FH is definitely the most common inherited metabolic condition, which results in a much higher risk, over 10 times, we usually say, for early ASCVD. What's actually here the reason? So it's inherited condition. There are 3 known genes which could be affected. One gene is for LDL receptor. The other gene is ApoB, which is part of lipoprotein. It's if we simplify it a little bit, LDL receptor is like a lock which could not function for the ApoB, which is like a key, which could also not function. So if the key doesn't fit in the lock, more lipoprotein LDL particles stay in the vessels. So, and there they cause eventually troubles. The third gene is PCSK9, which regulates the amount of LDL receptor, amounts of locks. So if there is less locks, then there will be more particles in the vessels. If I simplify it a little bit. So if one copy of that gene is affected, we have the heterozygous disorder, which leads to 2 to 3 times elevated cholesterol levels. If both copies of the genes are affected, fortunately, this is very rare condition. The LDL cholesterol is elevated at least 5 times. What's the problem here? So the problem is that this disorder is vastly under recognized. So less than 5% of children have appropriate diagnosis, and less than 10% of adults globally have this appropriate diagnosis. So that means around 2 million adults and 500,000 kids in Europe alone. And this population is at a higher risk. So the life expectancy is reduced almost 16 years if this disorder goes unrecognized through the life, which is comparable to many severe diseases. So it's in order, if we want to really normalize the long-term risk for cardiovascular complications in this group, we need to detect this patient and start to treat them early. Ideally, we need to start treatment in prepubertal kids at the age of around 8 years. And if they are treated continuously and regularly, they could normalize their long-term risk. So it's worth of putting our efforts at
one of the things from listening to you, clearly, we need to debunk the myth that FH is a rare disease. The numbers that you're describing, they're high numbers. And isn't it the case that the onset then of problems, if you will, with this particular condition is much earlier, much younger? So you're seeing cardiac events in a much younger age profile.
Exactly. So in especially in young adults, there is a huge difference with excess of cardiovascular complications as compared to the people without this disorder. So there's a tendency of definitely complications at a younger age.
Yeah, so we're going to talk more about FH later on in our discussion. But now, as we're talking about this, it's very often the case that we forget that the stories that are actually about real people. So real people are affected in a very real way. And so now I'm going to share with you a short little video which shares three stories, really. One from an individual living in Canada, one in the US, and one in Switzerland. So we'll just look at that for a few minutes and come back to our conversation after that.
In 2012, started having some heart palpitations while I was running on the treadmill. Never felt anything like that before. Contacted my nurse practitioner and let her know what was going on. For the next 9 years, I was in and out of the emergency room, complaining about the same issues, going back and forth, symptom after symptom, a heart attack, a TIA, and still not having a doctor to know something is going on, more questions should be asked, more tests should be done, and none of that was done. It took a stroke and near death to find that. I just felt like the healthcare system had failed me.
In November of 2015, I was at work, and it was something as mundane as just walking down a hallway and feeling short of breath. And thinking that was unusual, I checked myself into a walk-in clinic here, and the doctor had asked me to get up on the table, and he was checking my ankles. Then he said that he wanted to send me to another clinic a week later, and that was for a stress test. Checking into that clinic, that's where they discovered arteries that were blocked. Been blocked for a long, long time. They said the blockages were big and that they were well established, and that I had suffered multiple heart attacks. But these were silent heart attacks, so I didn't even know I was having them. So I was in kind of a fight, and I didn't even know I was in the ring.
J'ai aussi toujours dans la tête ce que m'a dit un jour un patient que j'avais rencontré dans un cours de réhabilitation. Il m'a dit: tu as eu de la chance parce que tu aurais pu mourir. Et donc ça a aussi complètement changé ma vie.
The general public might not be aware of ASCVD and the importance of staying on top of regular appointments, blood work, and then all of the things that we already know. It's a silent killer. Making sure that we're doing everything right, eating a healthy diet and getting lots of exercise.
Mais je pense que la première chose, c'est vraiment de le reconnaître, de le savoir, de le reconnaître, d'en discuter et de pas le nier.
I guess cholesterol is a thing that builds up slowly over time, and it's a ticking time bomb, I guess.
I'm not ashamed that this happened to me. Heart disease can happen at any age, anywhere, anytime. Our children, our grandparents, our sisters, our cousins, everyone should be educated on heart disease. Everybody should know the symptoms. Just like you get your mammogram every year, I now get my LDLs checked every 6 months. I go to my cardiologist every 6 months. You are the CEO of your life.
Part of the real crisis is that I think we've become too complacent. I don't think we're seriously addressing this enormous burden on society. So as I said, hearing those stories really, brings this down to the reality that we're talking about real people here, living with an invisible condition until something happens, and very often that's catastrophic. It's a heart attack or a stroke that can be fatal. So to that end, and I alluded to this earlier, at the Global Heart Hub, as a community of patient organizations, I suppose you could say that we're just staggered by the fact that there is an almost complacency or acceptance around the impact of cardiovascular disease globally. Why is it that we accept this level of disease burden when we know what the causes are, and by and large we can actually prevent and reduce the serious outcomes? The impact is not fully grasped, I believe, by governments, by the general public, and indeed even by the healthcare community. And really, when you break it all down, as we've heard, LDL-C, or bad unhealthy cholesterol, is at the root cause, not the only cause, but the primary driver. And in that context, we know that very recently the World Heart Federation, for example, recently developed what they call the cholesterol roadmap. And I know that one of our panelists, Magda, was very much involved in that project. And really, it's a call to all of us to implement change. We need to really challenge the status quo, and we need to be quite vocal about this. And at a last quarter of last year, the Global Heart Hub, in our annual Unite meeting, we launched what we call the cholesterol action plan, the Global Cholesterol Action Plan. And this really represents the voice of the global patient community. And the idea here is that we want to build a ground up movement. We want to provide our patient community with the tools to start to rock the status quo and to really challenge what's going on and bring this issue to the fore. And I just mentioned that in the Cholesterol Action Plan, we have really 4 primary goals. The first goal is that we want to build alliances at country and regional level to address the urgent need to reduce cholesterol-related ASCVD. The second goal, and it's related to that, of course, is to raise public awareness. For some reason or other, it's not that people have not heard of cholesterol and ASCVD, but we really need to improve their understanding of the serious risks of unhealthy cholesterol levels. And then obviously we want to activate these alliances. We want to do something about this. We want to mobilize the alliance to roll out an integrated advocacy initiative. The end game is we want to improve high cholesterol detection and management. And that's really what we want to move on to next, looking at how we build that momentum. Now, 2 of our panelists, Fernanda and Magda, they come from the patient community, and they have very valuable experience across their work, not necessarily specifically in cholesterol. And if I can come to you first, Fernanda, can you tell me what the current situation is in Brazil with regard to cholesterol, and why signing the Global Cholesterol Action Plan was so important for you and your organization?
Yeah, Neil. Brazil is a big developing country, as you know, with continental dimensions and with more than 200 million people, and has around 300,000 sudden deaths per year. And we know that at least 80% of this death relates to ASCVD and could be avoided or postponed with preventive care and therapeutic measures, as we heard from the doctors. And due to this scenario, in 2021, Instituto Lado a Lado did a survey that is heart health and cholesterol. And we heard 1,000 respondents, 55% women and 45 men. 68% are users of SUS, our public health system. And the objective of the survey was joining data, not only for our awareness campaign, as you mentioned, but also to give us more arguments for advocacy activities, that is our core. The collected data draws us attention that 1/3 of the participants does not know that cardiovascular disease are the main cause of Brazilian adults' death. And the fact that 2/3 of the respondents have comorbidities also stood out. 24% of them have high cholesterol and 30% have hypertension. The respondents also said that stroke, heart attack, and heart failure worry them more than cholesterol. What is interesting, because high cholesterol is an important risk factor for stroke and heart attack. And they also said that cancer is the disease that scares most the population between 40 and 65 years old. And neurological disease, such as Alzheimer and depression, also haunt. And after these findings, we have already run 2 webinars dedicated to cholesterol, and our president wrote an open letter addressed to healthcare managers, politicians, HCPs, the press, and general population, because we know that diagnosing high LDL cholesterol can be challenging, as there are usually no signs or symptoms, as you mentioned before, and we need to put even more focus on ASCVD in Brazil. So considering these numbers and this reality, you can see why it's so important for us to sign the cholesterol action plan and to participate in a task force to reduce the risk of premature CVD death in Brazil.
Thank you, Fernanda. And we do value your engagement in this. It's so important that we have a global community working on this. It is staggering, though, isn't it, that with all the information we have, all the knowledge we have, that you have those statistics coming out of your country around lack of understanding. And interestingly, the fear of cancer. I very often myself refer to ASCVD as the cancer in the heart world, because it's this slow build-up that eventually leads to a cardiac event. We'll come back to you again, Fernanda. Magda, we've already alluded to the fact that your particular interest is FH, which is one component of ASCVD. You could probably argue that this is where the low-hanging fruit is in terms of bringing change, in the sense that we can find it, right? And we can intervene and we can prevent largely negative outcomes. From your point of view as a representative of the European FH community, what does the cholesterol action plan mean to you in the context of your overall agenda?
Indeed, we are an organization that advocates on behalf and supports people, patients, the ones who have been identified, and citizens who have not yet gotten the diagnosis and support with familial inherited lipid conditions. And just like Dr. Goodman earlier alluded, it's FH and Lp(a). It is, however, a fraction of wider group of conditions and diseases. And so this particular platform, the action plan, is an opportunity for all of us to jointly activate and maybe hit the note among the policymakers, budget owners, decision makers, who will then realize that ASCVD is a public health issue which needs to be resolved. And so building alliances, collaboration with Global Heart Hub and other forming and established organizations, societies in Europe and internationally is extremely important. Those four key four recommendations are important because this is what we are already doing on a daily basis. It is building effective alliances, reaching out beyond your usual suspects, collaborating closely with medical societies, with the global registry on one hand, but also with other patient organizations. FH Europe specifically is expanding partnerships, memberships, collaborations. We are a member of the World Heart Federation on one hand, and then EuroRDis, which is the community of rare diseases, on the other side. We have, together with Global Heart Hub and other organizations in Europe, societies, but also industry representatives, formed each European Alliance for Cardiovascular Health, where together we build on the knowledge, we raise awareness. And so I think that the issue of ASCVD is so huge that it needs repetition, constant repetition, but at the same time, I think it requires approaching the issue from different perspectives. And so the action plan beautifully complements the WHF roadmap on cholesterol, but also other documents and calls like the Prague Declaration, of which I hope I will have a chance to talk to. But ultimately, it comes down to us all together working towards one joint mission, and that is putting stop to unnecessary heart attacks and even deaths as a result of atherosclerosis.
Yeah, and I mean, this is a problem that's not going to go away. We know that, and from an advocacy point of view, very often in advocacy, it's the minority group, it's those that are, that feel on the margins, that are struggling to have their voice heard. Ironically here, this is not a minority sport. This is something that is affecting virtually the majority of the global population. So we really do have to come together and really wake up to the fact that we must work together, and we can work together, and there are things we can bring about from change. Now, you have a long experience of building successful alliances. I mean, FH Europe, I think, is one such example. Can you share with us what you see are the keys, are the key to building a successful alliance from your experience?
Absolutely. When I first started with FH Europe, that was just a few months before COVID. And at that time, we were a community, a network of patient organizations of which hardly anyone heard. Believe it or not, as terrible as it might sound, COVID was a little bit of a silver lining, because it has manifested the importance of prioritizing cardiovascular health. And that was the moment when a lot of groups realized they need to do something. And I think that was a moment when we as FH Europe as well realized that acting alone and advocating specifically for familial hypercholesterolemia is not going to take us far, because the problem is so vast. And as a result, this was the moment when we see the opportunity, building alliances, fighting together, raising awareness. And as I mentioned earlier, that was as well the moment when we started reaching out beyond the usual stakeholder groups. Obviously, our growing network of patient organizations, of which many are also members of Global Heart Hub, which demonstrates the need to replicate some of the messages. Societies, medical societies, partnership with the Global FH Registry, data and evidence-driven messages that we base our advocacy on, reaching out to HTA bodies, collaborating with experts in social sciences and trying to understanding behaviors and what stops people from acknowledging some of the problems. And obviously building expert groups. Professor Groschel is one of our advisors sitting there, building on models in different countries. I think the key here is recognizing that not all of us have the capacity, not all of us have the resources. We need to be the best we can at what we do, while we complement with expertise, resources of other partners in the wider community.
Yeah, and I think your point about COVID is interesting, because I think COVID really fanned the flames of cardiovascular disease. I think we've realized, or hopefully people have realized, that we have this massive proportion of our population living with underlying ASCVD, and when COVID hit, they were the ones that were hit worst. And so we know that there could be another COVID around the corner, and we need to be far more resilient, and we need to be prepared. So that's a very important point. But you have been singularly successful, Magda, with your group, right, in moving the dial on building an alliance around FH. And I reference particularly the Prague Declaration. Tell us about that, why it's significant, but more importantly, how did you bring this group together? How did FH Europe get to that point?
I think it's a combination of factors. It's a combination of people who actually believe, trust, and are absolutely committed. Ur himself was pivotal in the whole process, because Prague Declaration, a document that was launched and signed and endorsed by a number of international organizations and individuals and politicians, which we delivered in September of last year, was actually building on success of the previous meeting, which took place virtually in Slovenia. And so what we were doing is basically building again on alliances and partnerships. It was the presidencies, the Slovenian presidency, collaboration with the rare disease community, joint action, and successfully delivering screening models based on some countries to the European Commission. And it was a bit of a very positive domino effect, which we seized as an opportunity. Ultimately, it was very much people in the countries who are pivotal in securing attention of policymakers, politicians, securing the big names and commitment of the governments who helped us push it further. So Slovenia, one of the countries which is a small country yet being at the forefront when it comes to early detection and successful management of people with inherited lipid conditions, with FH here specifically, a model recognized worldwide, help us build recommendations, paper, bring together the World Heart Federation, societies, individuals. And so building on that, we moved to Czech Republic, where we had a very strong patient group who then collaborated with the Senate, and under the presidency, the Czech presidency brought to the forefront the Prague Declaration with 7 asks. Furthermore, if we can fast forward, the Minister of Health of Czech Republic took the Prague Declaration and actually, when handing over the presidency to the next country, which is now Sweden, specifically referred to FH as a condition that it requires urgent action and attention, and put the Prague Declaration as a model to early screening, prevention, and one of those, as you said earlier, low-hanging fruit when it comes to healthcare system solutions. Copy of this letter went to every single Minister of Health within the European Union, and now it's back to us, our advocacy community, to build on that and continue on demanding focus, funding, attention, prioritization when it comes to early cholesterol test to avoid development of ASCVD, heart attacks, and premature deaths.
Yeah, perfect segue to Professor Graschel, because as we said, it's the low-hanging fruit. And what you have done in Slovenia is absolutely remarkable. As Magda mentioned, I come from a small country, and I believe Slovenia is probably even smaller than mine. And yet you have managed to introduce what I believe is a first in Europe, a national pediatric screening program, which now I believe has successfully screened up to 90% of FH. This is remarkable. Can you tell us more about how you did that? What was the key to your success? How did you bring all the stakeholders together, and how did you bring about that huge change?
Yeah, thank you very much. Actually, I might actually add to these kind words of you in Magda that we are not like the only ones. I mean, the Dutch system of cascade approach with some other similar approaches like Norway, Czech Republic, I think should be here also mentioned as a very strong approaches. Our approach was a little bit different. So in Slovenia, we have very good network of primary care pediatricians, which take care. So each child has own designated primary care pediatrician, and we have these preventive visits of healthy children. And at one point, at age 5, actually, we managed to add the measurement of total cholesterol to this system. And afterwards, actually, it took some years. It was not overnight. Afterwards, we managed also to add the second step with genetic testing at the lipid pediatric center, and also the third step of cascade screening of the child, of the parent with highest level of cholesterol. So now it's a 3-step program. It's well implemented, but it took us, I would say, several years really to be successful. But I think for each new country, it might be a bit easier, because now we have much more stronger consensus, better recommendations. I think there is like much better momentum. But of course, you have different stakeholders here. You need to convince. You need to talk to the primary physicians and really be in constant contact with them, providing them evidence, talk to them, providing them some, I would say, plausible explanations. You need to educate people at all stages, medical students, residents, later on fellows, and so on. You need to talk to the public, you need to talk to convince public, you need to talk to the patient societies, you need to talk to politicians. So I think each stakeholder needs to have a little bit separate, different type of approach. But I mean, it's possible. You just need to, I think, probably not the same way is applicable in each country. So each country has some opportunities where it could be done. I mean, it could be a different age, or it could be different approach. But still, I mean, if there is a will, I think it's doable anywhere.
Yeah, well, I think it's an exemplar of excellent advocacy over many years. And we'll come to Sean in a few minutes about how we mobilize and engage with the medical community on ASCVD. But firstly, Fernanda, your organization is a very broad-ranging cardiovascular organization, and you also have been involved in building alliances on other topics, not necessarily around cholesterol. What are the big challenges that you have experienced that we perhaps could learn from?
Yes, new working network is part of our DNA. So it's written in our name. So we are side by side for life. And this is why we are so active in Global Heart Hub, for example. We learn a lot with other groups, with organizations from other parts of the world, some with social and economic situations similar to Brazil, and other quite different, but important to inspire us. Two recent examples of alliance in cardiovascular disease are the partnerships with the, again, Global Heart Hub to localize, launch, and disseminate the content of the heart failure patient and caregiver charter. We were the champion of this initiative in Brazil, and we invited two very important medical organizations to validate it. One is the Department of Heart Failure of Brazilian Society of Cardiology, and the other one is the Brazilian Heart Failure Network. We did the launch in September during the month of the campaign for awareness campaign for cardiovascular disease. We did a live event and has been working on the communication of this material since then. And the other case is the production and dissemination of a guiding document about heart valve disease in Brazil. It's something that has never happened here. We wrote this document. It's a 50-page document. It was published in 2022 with the participation of 6 Brazilian reference centers on heart valve disease, one from Amazonas, one from Bahia, one from Rio Grande do Norte, and 3 from São Paulo. We not only mapped the situation of the heart valve disease, the valvopathies, but included a critical approach to design an advocacy plan. And now, in the Q2 2023, we'll do a roadshow with the heart valve disease coordinators of those reference centers, knocking the door of the secretaries of health to present some suggestions and to put emphasis in what we need to do as the society, the civil society, and the specialists. We can work together, and also with other organizations like ours.
Yeah, I mean, I think what you're highlighting here is clearly you need to be, you have to persevere, you have to be persistent, but it's all about bringing people together, and that's the key thing here. Sean, if I can come to you, Ur has given an example, and he's called out the fact that there's so many stakeholders, and in general terms, we have the citizen who becomes potentially a patient or a high-risk individual. We have healthcare professionals, and we have policymakers. From a healthcare professional clinician perspective, Sean, what are the barriers do you see in terms of grasping the nettle of ASCVD? Why is it that, because this is what doctors see every day in their surgeries. So why is it, do you think, that we have allowed this situation to develop to where it is without anybody really, being fired up about it?
It's a great question, Neil, and I don't pretend to have the answers, but I'll speculate a little bit on some of the the barriers to more widespread understanding, awareness, and doing something about this. I think 20, 30 years ago, we could measure cholesterol levels, we could identify people that had high levels, and we knew the association between, for example, the unhealthy cholesterol, high levels of bad LDL cholesterol, and people developing and dying from atherosclerotic cardiovascular disease. But we didn't seem to have a way of managing it. And that has been a dramatic change, at least in my practice lifetime. There's been outstanding clinical research that's been performed around the world in the sort of highest quality trials, led not by the pharmaceutical companies necessarily, but by university researchers and on the ground clinicians looking after patients that aren't researchers by trade. And when you look at the totality of information now, we have incredibly safe, very effective, well-tolerated, inexpensive in most cases treatments for lowering LDL cholesterol. And so I think that that's been one of the biggest gaps is, 20 years ago, people, even physicians, healthcare providers might not, yes, they might have been aware of it, but they didn't feel that they had something that they could do to make a difference. Now we have incredible tools. And so I think part of this is a historical sort of baggage that we have that we need to overcome, and I think awareness is the first step. And I would say to the audience out there, get engaged. Don't rely on your healthcare provider by themselves to be your best advocate. Not that they aren't trying to be, they're just overwhelmed like everybody else with so many things going on. But you can be your own best advocate. Know your cholesterol levels. Talk to your healthcare provider about how you can assess your atherosclerotic cardiovascular disease risk, including LDL cholesterol, the unhealthy cholesterol. So I think the other piece of it, or the other barrier, has been we as a healthcare professional a group have not engaged our patients, our partners, to the extent that we should have. And now we're scrambling to get them engaged, empower them with information, and help them be their own best advocates.
Yeah, well, hopefully that's one of the positives that will come out of the Cholesterol Action Plan, is that we're trying to create those alliances, we're trying to create those relationships. And when you look back at the onset of AIDS or the onset of COVID, the big crisis was we didn't know how we were going to, or the experts didn't know how they were going to tackle these, right? The irony here is we know the causes, we can detect it, we can measure it, and we can actually reduce the burden. So there is a piece here where somehow we need to mobilize all our citizens, all our community. And I'm not sure that any of the panel have any strong views on what the key to that is. Is there some piece of this that we're missing? I'll open that to the floor. Any of you care to? What's the magic key here?
There's been a lot of investment done, as Sean has just highlighted, in terms of development of new treatments, understanding the disease. And I'm going to partially repeat what Sean said. The engagement of patient and citizen has been maybe limited. And what we have observed, that there has been a lack of social sciences engagement and understanding behaviors, how cholesterol is being perceived, the general public understanding of the role of cholesterol. Unfortunately, there is a certain level of stigma attached to it. And you open this meeting by saying that very often it is considered as there is a relationship between your lifestyle, your own fault, just like we observe it with cancer, like lung cancer, for example. And I think it's an important piece that's missing, and hopefully we as a community will drive that, understanding how people think, how people react, specifically in FH or inherited lipid conditions. There is an element of genetic stigmatization and inequalities. And certain behaviors, unfortunately, are fueled by the social structures. People don't want to be identified. People are not willing to have their genetic results displayed because they pay high consequences for that. So I think to respond to that, I would say we need to understand better what blocks people, what inhibits their willingness to understand. And there's one other element, in my opinion, observing patient community. We have given entire trust and almost offloaded the responsibility for our health onto the clinicians, the doctors, who, as Sean highlighted, are very often very, very busy and they cannot know everything. And I think power to the people as well as responsibility. And I would say, you know, just like when you go and buy your car, you research it. When you have a condition, research it, because you probably will be more equipped to go back to your clinician. So I think personal engagement and personal responsibility about our own health. So
Yeah,
two things, in my opinion.
Yeah, I think you make great points there. The latter, the patient-doctor relationship needs to change. Absolutely. Historically, I think we went to doctors, they were God, and we just did what they said. Not saying they're not knowledgeable individuals, but the responsibility remains with the individual. And we have now greater capacity to learn more, to understand better, and so forth. So I absolutely agree that that dynamic has to change. And you also make the point about the behavior piece. So maybe there's a greater role here for behavioral science. Because it's one thing to educate somebody about something, you know, tell them that this is your number and as a consequence of this, you know, this can happen. But actually getting them to make the change, that's where behavioral science has a contribution. So good points made there. Sean, can I just jump back to you and indeed, if either of you to respond to this. Would you think that perhaps in the case of cardiovascular disease, because we have advanced so quickly in the treatment, that's where all the investment is. It's all on the acute care phase, the fancy stents and all the new technologies, which is great. But where is the investment in prevention? Where is the approach to prevention? Where's the strategy for prevention? In fact, I would challenge anyone to tell me of a country in the world that has a strategy for CVD prevention, specifically how they're going to prevent ASCVD.
It's a great point, Neil. I think you've hit the nail on the head. I think that at least the healthcare system in my country has been historically focused on putting out fires, so to speak. You know, dealing with the acute heart attacks and the strokes, for example, as a manifestation of atherosclerotic cardiovascular disease, and that's just the tip of the iceberg. We know how worldwide the impact is and how silent this is until one of those events occurs to one of us or to our family members. And so I don't think that our healthcare system and the investment in it has been appropriately shifted over the course of time to look at preventing or at least modifying the risk, for example, for ASCVD. It can be somewhat of a daunting task when you look at the numbers. Again, if we're talking about 2 billion people at risk for atherosclerotic cardiovascular disease globally, I can appreciate how, you know, politicians, leaders of our countries and regions in our country, it's a daunting number of people to sort of think about, okay, how do I do this? It's almost easier to sort of throw resources and time and energy at an obvious thing, like how do we manage this acute heart attack or this acute stroke. But I think with the building of alliances, enhancing the public awareness, activating those alliances so that we can improve detection, for example, and management of cholesterol is one example in ASCVD. Those are the things that we need to sort of now focus on to not exclude, of course, the acute management, but to shift the focus of our patients, of our citizens, of our population, and then to empower them to get the attention of our politicians and our leaders to say, we can't just continue to, manage the tip of the iceberg and put out the fires. We've to take a step back and try to prevent these things from happening wherever possible in the future.
Yeah, and I think in a word, because I'm out of time now, I think we need to start looking at this from the point of view of not a cost, but a benefit and an investment. We need to invest in this. It's amazing. We've run out of time. Sorry, Ur, I was hoping to get back to you on this question as well. Conscious of everybody's time, can I start by thanking each of you for giving up the last hour of your time today and of your busy schedules. I think it's been a very enlightening conversation, and I hope those listening will have picked up some nuggets of inspiration in moving forward with the cholesterol action plan. It's great to see that we actually had lots of patient groups joining us, saying hello to you, Magda and Fernanda. And so I just want to thank you all, thank those who have joined in. And if anybody who has joined in today and has any questions, feel free to post those questions to us on the Global Heart Hub LinkedIn page. We'll leave it at that, and thank you all, and hopefully we'll meet again for another conversation someday soon. Take care. Bye.
You too. Thank you, Neil.
Thank you
Bye.
very much.